Hi there. Thank you for participating in the Office of Licensing Initial Applicant Orientation. Today's module is all about crisis services. Our presenter today is Denise Hall, DBHDS Crisis Systems Manager. Denise, you can take it from here.
Thank you. This is Denise Hall with the Division of Crisis Services, and I was speaking with you today about the Division of Crisis Services and the Crisis System Overview. Let's start with the historical behavioral health crisis response so that you can get a better understanding of where the system started. The system experienced challenges to provide timely access to crisis services. The system experienced challenges to meeting the individuals where they are at. And the system over-relied on law enforcement, the criminal justice system, and hospital emergency rooms to respond to behavioral health crisis. This created capacity issues among our state psychiatric hospitals and an over-reliance on emergency medical departments. As you can see from the graphic, the person in crisis was served through police, EMS, psychiatric departments, psychiatric hospitals, rather than in their community. The current crisis system, under the Crisis Now framework, identifies important ways to access the system. Someone to call, that being crisis call centers. When someone calls 988, a trained crisis worker will provide support such as safety planning, referrals, and a listening ear. If needed, crisis workers can connect to the full continuum of services through Virginia's Marcus Alert system. Appropriate calls to 911 can be routed to the 988 call centers. Someone to respond, mobile crisis response. Teams are deployed in real time, 24 hours a day, to the location of the individual experiencing a behavioral health crisis. These rapid responders provide on-scene evaluation, intervention, and connection to follow-up resources, and somewhere to go. Crisis stabilization sites, 23-hour crisis receiving centers, and short-term residential crisis stabilization units provide a safe, secure, community-based environment for assessment, resources, and emergent crisis treatment. The crisis continuum overview, as shown below, is in the crisis continuum comes under the bubbles identified. We will have brief information about each bubble and how they connect. As you will note, under each bubble, the associated license is identified. The first bubble, regional crisis call centers, as you can see, 24/7 mobile crisis response, community stabilization, non-residential, 23-hour and crisis receiving centers, crisis intervention or CTAC, crisis residential stabilization, CSU or CTHs, CSBs providing emergency services, and regional educational assessment crisis services habilitation, or our REACH programs. You will note that some of these services are not licensed, but they provide a critical resource and connection to licensed services. We'll start with regional call centers. A crisis call center offers real-time access to a trained crisis worker 24 hours a day, 7 days a week, 365 days a year. They also provide clinically supported 24 hours a day and provides telephonic crisis intervention services to all callers. They are required to meet the National Suicide Prevention Lifeline, or NSPL, operational guidelines regarding suicide risk and assessment and engagement, and offer air traffic control quality coordination of crisis care in real time. Best practice for crisis call centers is to offer text and chat options to expand access engagement of all communities in care. These are currently in development. Comprehensive crisis continuum for regional crisis call centers and program qualifications, as stated, NSPL, National Suicide Prevention Lifeline membership and accreditation, and they must contract with at least one of the 5 Virginia regional hubs. The minimum expectations to operate as a regional crisis call center: operate 24 hours a day, 7 days a week, 365 days a year, and are staffed with clinicians and other team members that respond to all calls received. We must assess risk of suicide and imminent risk in the manner that meets NSPL standards and adheres to Virginia's Marcus Alert policies. They coordinate connections to resources and the crisis continuum of services and operate within the DBHDS data platform. Again, they are not licensed, but they are a critical component of the overall comprehensive crisis continuum. These are the regional crisis hubs, as indicated previously. Region 1 is with Region 10 CSB. Region 2 is Fairfax Falls Church. Region 3, New River Valley. Region 4, Richmond Behavioral Health, and Region 5 is Western Tidewater. A hub sits within each 5 regions of the state. Mobile crisis response. Mobile crisis response is an essential component of the comprehensive crisis care no wrong door system. This service is provided 24 hours a day, 7 days a week. It includes prevention of acute exacerbation of symptoms, prevention of harm to the individual or others, provision of quality intervention in the least restrictive setting, and development of an immediate plan to maintain safety to prevent the need for a higher level of care. Mobile crisis response is under this outpatient crisis stabilization license 07-006. Of note, community stabilization also falls under this license, but they are very different services. The goal of mobile crisis response is to rapidly respond, assess, and intervene early for individuals in behavioral health crisis. Services are deployed in real time to the location of the individual experiencing the crisis. Provider requirements must be licensed by DBHDS for mental health, non-residential crisis stabilization services, and enrolled with DMAS. Obtain and maintain an active MOU or Memorandum of Understanding with regional crisis hubs. Engage with the Virginia Crisis Connect data platform, and information can be requested here, crisis_services@dbhds.virginia.gov. Complete DBHDS approve mobile crisis response training within 90 days of hire. Specific staffing requirements can be found in DBHDS rules and regulations for providers and the DMAS Mental Health Services Manual under Appendix G in Comprehensive Crisis Services. All mobile crisis response services must be delivered on-site, with the only exception of the assessment, which can be completed by an LMHP. Listed below are the mobile crisis response training contacts, which you would notify of your interest in participating in a mobile crisis training. All of the providers provide the same treatment. Training. If your region is full, you can contact another region to see if they have availability and slots for training. Community stabilization, this is non-residential. Community stabilization services available 24 hours a day, 7 days a week to provide a short-term assessment crisis intervention and care coordination to individuals experiencing a behavioral health crisis. Services may include brief therapeutic and skill-building interventions, engagement of natural supports, interventions to integrate natural supports in the de-escalation and stabilization of the crisis, and coordination of follow-up services. These services involve advocacy and networking to provide linkages and referrals to appropriate community-based services and resources, assisting the individual and their natural support system in accessing other benefits for assistance programs for which they may be eligible. The goal of this service is to stabilize individuals within their community and provide crucial support to individuals and their support systems during critical periods. Provider requirements: they must be licensed by DBHTS for mental health, non-residential crisis stabilization services, and enrolled with DMAS, have an active MOU, Memorandum of Understanding, with a regional crisis hub, those contacts previously listed. CSB providing this service must adhere to the terms of the performance contract. Assessing the service. Between an initial mobile crisis response and entry into an established follow-up service at the appropriate level of care. As a transitional step down from a higher level of care, if the next level of care or service is identified but not immediately available for access, or as a diversion to a higher level of care. Again, mobile crisis response and community-based stabilization do appear under the same license. They are, however, different services. Crisis receiving centers. 23-hour observation and crisis receiving centers, or CRCs. Crisis receiving centers are programs that provide licensed site-based crisis observation, provide outpatient assessment, and treatment for a period of up to 23 hours and 59 minutes. CRCs fill a critical role in an effective crisis system by accepting referrals from a crisis line, mobile crisis teams, law enforcement, and through walk-ins and self-referrals. The goal of a CRC: determine the immediate needs of the individual in crisis, provide appropriate treatment throughout the 23 hours, and coordinate care for continued psychosocial needs and supports, as well as health literacy and counseling for the individual's return to the community. Those associated license numbers can be seen below this slide. The goal of this service is to assess crisis and psychosocial needs during the 23-hour service to determine the best resources available to the individual to prevent unnecessary hospitalization. Provider requirements: must be appropriately licensed by DBHTS and enrolled with DMAS. Site must be center-based, recliners instead of beds. Walk-in or police drop-off, no wrong door entry. Specific staffing requirements, again, can be found at DBHTS Rules and Regulations for Providers and DMAS Mental Health Services Manual, Appendix G. Required activities: initial assessment by an LMHP type to determine medically necessity and service appropriateness. Psychiatric evaluation at admission by a psychiatrist, nurse practitioner, or a physician's assistant. 24-hour in-person nursing with a nursing assessment at admission to determine medical needs. CTACs, or Crisis Intervention Team Assessment Centers. Individuals experiencing a crisis and have encountered or contact with law enforcement is imminent may be transported by any safe means to a Crisis Intervention Team Assessment Center, or CTAC, where they will be greeted by, at minimum, a CIT trained law enforcement officer or security officer who may then accept legal transfer of custody of any person under an emergency custody order, an ECO, as defined by the Code of Virginia. Once at the center, programs will commence the code-mandated pre-admission screening as soon as practical, whether in person or by secure virtual communications. As individuals, persons with lived experience, peers are encouraged to be available during the de-escalation and evaluation process to provide emotional support. Feedback about the involuntary custody process throughout the individual stay at the CTAC. CTACs are not licensed by DBHTS. However, again, they serve a critical component and connection to our licensed services. The program qualifications for a CTAC is oversight for the CTAC program is managed by the department's Division of Crisis through designated CIT assessment site program coordinators. Additional information can be seen in this Virginia code. Note, CTAC is an assessment site, and law enforcement maintain the custody of the individual when an ECO or emergency custody order has been issued. The services within are the same as they would be anywhere else a crisis may occur. Emergency services provides the same service they would anywhere else when conducting an assessment and completing a pre-screen. Law enforcement do not provide oversight or supervision over the clinicians' peers that are on site. Residential crisis stabilization units and Crisis Therapeutic Home, CTH. Crisis stabilization residential services occur in a non-hospital, community-based crisis stabilization residential unit with no more than 16 beds. Residential crisis stabilization units, CSUs, may co-locate with their 23-hour crisis stabilization, or CRC. The goals of residential crisis stabilization unit services include, but are not limited to, the goals of the residential crisis stabilization units, repetitive, stabilize the individual in a short-term community-based residential setting and support the individual and natural support system. Reduction of acute symptoms, and identification and mobilization of available resources, including support networks. Refer to the DMAS Mental Health Services Manual for program requirements and service definitions. All of these are found in Appendix G under Comprehensive Crisis Services. The associated licensing information is below on this slide. So the goals of the service: stabilize the individual in a community-based setting, reduce an individual's acute symptoms, and identify and mobilize an individual's available resources, including support networks. Provider requirements must be appropriately licensed by DBHTS and enroll with DMAS. Site must be non-hospital, community-based with no more than 16 beds. CSUs may not be reimbursable by Medicaid if more than 16 beds. Please note please contact your assigned regional crisis manager with questions related to bed capacity. You may also contact DMAS at enhancedbh@dmasvirginia.gov for more information concerning the federal regulations related to Institutes of Mental Disease, or IMDs. Specific staffing requirements can be found in the DMAS Mental Health Services Manual, Appendix G, Comprehensive Crisis Services. Related activities include initial assessment, by an LMHP or LMHP type to determine medical necessity and service appropriateness. A psychiatric evaluation at admission by psychiatrist, nurse practitioner, or physician's assistant, 24-hour in-person nursing with a nursing assessment at admission to determine medical needs. Note, Crisis Receiving and Crisis Stabilization Center, CRC, is a crisis service location that may offer a CTAC, a CRC, and a CSU in the same location, with access to the services across the spectrum of care between them. ESB, Emergency Services, also known as ES. Emergency services staff complete pre-admission screening and civil commitment hearing activities as required by Chapter 8 and Title 37.2 of the Virginia Code. They are not a licensed service, but again, provide a critical connection through all of the comprehensive crisis continuum. Regional Education Assessment Crisis Services Rehabilitation, or REACH. The REACH program was established to provide a statewide crisis system of care that serves individuals that reside in the state of Virginia and is designated to meet the crisis support needs of individuals who have been diagnosed with a developmental disability and are experiencing a behavioral health or behavior-related crisis event, which puts them at risk for homelessness, incarceration, hospitalization, and/or danger to self or others. The mission of the REACH program is to provide services supports that allow the individuals to live the most inclusive life possible in their community, which includes access to appropriate and effective crisis and prevention services. Please see the associated license information and numbers at the bottom of the slide. The goal of the REACH program is to provide services supports that allow the individuals to live the most inclusive life possible in their community, which includes access to appropriate and effective crisis and prevention services. Provider requirements: each of the REACH regional programs must be licensed by DBHDS for the respective residential crisis community stabilization and non-residential crisis community stabilization services being provided. The program must adhere to the guidelines established by DMAS in the Developmental Disabilities Waiver. Those are in BI, FIS, and CL Services Manual. The program must adhere to DBHDS REACH standards. Core services offered: mobile crisis response, community-based stabilization, crisis therapeutic home, youth and adult. Services typically provided up to 15 days, prevention and follow-up resources and support. Thank you. Please submit any questions related to any crisis services covered in this presentation to the email below, crisis_services@dbhds.virginia.gov.
Thank you so much, Denise. This now concludes the crisis module of the initial applicant orientation.